This is Julianne Palmer, and I'm continuing with my assessment now of the chest and the thoracic cavity. First thing I want to do here is I'm going to set my patient up. Maybe have him scoot back just a little bit so we're in the camera. Okay. I'm going to have the patient cross his arms across his chest, and that way we can hold his arms out. And what we're looking here is that I'm looking for the shape and symmetry of the chest. I'm also looking at the color and looking at what the work of effort is of his respirations. And so right now I'm just looking at the symmetry and the color. Okay, now I'm going to assist my patient to lay him back. Okay. I would say the symmetry and shape are within a normal area, normal size. The next thing I'm going to do is palpate around, and I'm going to be checking for any kind of tenderness, bulges, any kind of depression, any kind of areas there that might indicate some type of abnormal growth or depression that might be noted in the chest. So right now I'm just going to palpate, starting up here, and just come down. And I want to work my way across to the other side. And I've asked the patient to let me know if at any time I touch anything that feels particularly tender to him. So far, I'm not feeling any kind of nodules, no knots or bulges, and he's not voiced anything being tender. Okay, looking at his chest with him laying down like this, the color is a nice normal pink. I'm not seeing any lines of veins or anything on the chest there. Now I'm going to look for the anatomical markings of this patient. First thing I want to do is check for his trachea here. I'm going to check for proper tracheal alignment. I'm going to palpate starting up here and go along each side of the trachea. Things that can cause the trachea to be displaced, something such as tension pneumothorax or patients with really significant congestive heart failure, that can cause your trachea to shift to one side or the other. And so we're going to go up here and measure around. And now I'm going to work my way down here to the base. And I want to note the suprasternal notch, which is just superior to the mandibular, or the angle of Lewis. And the angle of Lewis is the point at which the second ribs attach to the sternum. Okay. Coming on down his chest here. I feel the sternal notch. And come down here to the end as I feel down through his sternum. I note the tip of the sternum there. You can also look for alignment on a patient. And there's what we call an imaginary line. And what I would do is start up here at the sternocleidoid area and locate my clavicle. And then my imaginary line would come down, middle here, and look at the patient's chest. And things appear to be aligned and normal shape. There's things when I had him sitting up and I was observing his chest for symmetry and things you want to look for. There's certain conditions that can cause the chest to be shaped abnormally, that can cause the patient to have some difficulty with their respiratory effort. One thing is called pectus carinatum. This is what we call the pigeon chest, and I always can think of a pigeon if I close my eyes and I see how the chest just comes out like this. There's a protrusion of the sternum area here. The other thing is pectus extravium, which is where the chest is wide and then it narrows down through here. And then the other thing is barrel chest. Barrel chest is more common in your older adults, and this is usually from loss of muscle tone, muscle strength in their thorax and their diaphragm area. Especially you can see more so in patients with emphysema, patients that have cystic fibrosis, patient who has kind of like the spine deformities here as well. Our diaphragm is what does most of the work of effort with the breathing process here. Your diaphragm, what you're going to notice on the right side here, it's going to be slightly displaced at a higher angle because of the liver pushing it up. So I'm going to feel down through here. Feel across. Okay. And patient notes no tenderness or anything. Certain things like blunt force trauma to this area can cause the diaphragm to rupture and compromise the patient's respiratory effort as well. And this would be an emergency in those situations. Other abnormalities that can affect the respiratory effort and pattern is the abnormal curvatures of the spine. You've got your scoliosis and your lordosis and your kyphosis, that as the curvature of the spine changes, it can displace the thoracic cavity here and can cause the patient to develop some difficulty with their respiratory effort. Okay, other things to look that tells you how this patient's respiratory and work of effort is. I can look at the patient's hands and fingers, and what I'm going to do is examine his fingers, and I'm looking for clubbing of the fingers. I'm also checking capillary refill of each of his fingers. I note no clubbing on this hand. He has good capillary refill. The hand's nice and warm. And we have a good pulse in that wrist. I'm going to come over to this side now, and again, observing the fingers for clubbing. And things look normal there. Check my capillary refill, which is good and brisk. Hand is warm. And he has a good pulse. That's good. You can also come up and look at the patient's lips, and you're looking for cyanosis. There's no evidence of cyanosis of his lips. They're nice and pink. There's no evidence of nasal flaring, which also can suggest some difficulty with respirations. I'm going to have him open his mouth and stick his tongue out. And his tongue is nice and pink also. So that's a good indication that he's also oxygenating well up in the tissue up in that area. Things that can cause clubbing of your fingers, again, your emphysema, some type of chronic hypoxic state, your cystic fibrosis, lung cancer. Those are the most common things that you see that associated with. As I said before, there's no venous patterns on his chest. Everything looks a very healthy color, no markings, no incisions or anything noted on his chest from past surgical procedures. Rate and effort is unlabored and normal. And now what I want to do is I want to listen to his breath, I want to listen to his lung fills and check the breath sounds, and I want to listen for any abnormal breath sounds as well at this time. So for just a second here, I'm going to kind of be quiet as I listen, and I'm going to be using the diaphragm of my stethoscope here, and I'm just going to ask him to breathe in and out. Breath sounds can be easily heard in all fields of the lung. They're nice and clear. I don't hear anything like any crackles, which can suggest like a pulmonary embolism, which suggests pulmonary edema or congestive heart failure state. Don't feel any kind of crepitus, which is what I call kind of like the Rice Krispie feeling under the tissue there of the skin. Patients can get that from certain type of bacterial processes that cause gas to form under the tissue. Also, tension pneumothorax, if they have leakage there into the tissue as well, you can get that crepitus type feeling. I didn't feel any of that when I was palpating the skin. If you felt crepitus, that is a situation that would require rapid attention and evaluation for the patient. Crackles, again, crackles is an indication of pulmonary edema or congestive heart failure. And again, everything sounded nice and clear. I didn't hear any wheezings in the lower base of his lung fields. Wheezing usually is associated with asthma, and you hear that because there's constricting of the bronchial tree as you get down into the lower fields. Rhonchi. Usually you hear rhonchi if you tell your patient to cough and clear their airway. Usually that clears it and it goes away, but I didn't hear any kind of congestion or anything that required him to take a deep breath and cough. Friction rubs, usually you'll hear those around the pericardial sac region. Those would be concerned because that can be an indication of a patient developing pericarditis. If I hear it in the lungs, that rub, it's like a coarse, crispy rub there. That would be concerns for a patient possibly developing pleurisy. Now what I want to do is check my patient for what we call phragmaticus, tactile phragmaticus. And what I'm going to do is I'm going to have him repeat 99 over and over as I go along and go down each side of his chest, and I'm going to feel for the vibration as the voice and the air moves through his chest. And what I want to feel is just a nice soft vibration of that as it moves down through his chest wall. Okay, go ahead.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
And really you can feel this much better when you're doing the posterior aspect of the patient, that vibration as it goes through there. But for the sake of time, we're only going to be doing the anterior assessment on this particular patient. The other thing, certain things that it can indicate, increased phragmaticus, and the loudness of it can suggest increased lung consolidation in there, possibly something such as pneumonia. Decreased tactile formation can be caused by certain illnesses such as emphysema, pleural effusion, or massive pulmonary edema. The other thing I want to do now is what we call a percussion, and listen for the intensity, pitch, duration, and the quality of it as we go down the chest. And so what I'm going to do is take the one finger and lay it down on his chest starting up here, and I'm going to tap on it as we go down. And it tends to get duller as you get down into the area where the liver is, and when you're over areas of muscle, the sound tends to get duller. So I want to start up here. I'm going to have him put his arms above his head. I think you can actually hear it better when the arms are up there. And again, it's flat when you get over areas of the bone and muscle. And I'm not sure you can hear that, but it has a very nice sound to it here. And go down here in the liver area, and you can definitely change. You can tell the change of the tone. Much more hollow. Yeah, that time. And his resonance, it sounds very good. That's the term you would use to describe a normal sound pattern through there is resonance. The quality, again, is kind of a hollow sound. Duration usually, it's like a medium duration. And the pitch of it's very low. Hyper resonance the pitch tends to be low, duration long, but the quality of it is more what we call a boom-like effect on this that you hear. Timpani is more of a higher pitch type sound. The pitch is more of a moderate, and the duration is more moderate long. More of a thud-like sound when you're palpating over the liver, and again, that's not what we're hearing. And all his sounds do sound normal here. Let's see, the next thing I'd like to do, this is just a quick and easy test that you can do to measure what his diaphragmatic excursion is. And what I'm going to do is place my hands on his chest. I'm going to pull my thumbs together and let them, not quite meet, but slightly meet. And then I'm going to have him take some deep breaths in and out. Okay, again. Okay, and as you can see, the thumbs go out with the breath and then comes back in, and his does feel like a normal pattern there. Certain things that can affect the diaphragmatic excursion is things like ascites, that can affect it. Also abdominal tumors, pain from fractured ribs or broken ribs, or a tension pneumothorax, that also can affect the patient's ability to breathe in and out very well. What I want to do now is just listen to some vocal resonance. I'm going to have him do a couple different things. I want him to do a whisper, doing 99. I want him to say the letter A, and I just want to hear the sound of those as it passes down through here of a vocal resonance. And, okay. And if you would, please. Say 99. And in this area here, I just hear very soft, very light whisper as it moves through the airway and down the bronchial path here. Again, things that can affect it would be any kind of consolidation in the lung fields that can affect it. But his was nice and soft and gently moved through without any type of problems. So this is the end of my chest and thoracic exam. And next we'll be moving on into the cardiovascular.